Good evening, everyone. And welcome to tonight's event on the Inclusive HIV Care Practice Guide for Overseas Born Gay, Bisexual, and Other Men Who Have Sex with Men Living with HIV. My name is Horace Wong, and I will be your facilitator this evening. I'm a senior lecturer in nursing at the University of Sydney, as well as a sexual health and HIV nurse. My research focuses on HIV, LGBTQ health, and migrant health, and culturally responsive care. So, as a migrant and healthcare professional myself, I am particularly interested in how we can provide care that is not only clinically effective, but also inclusive and responsive to the broader realities of people's lives. And I believe this shared interest is also what brings many of you to tonight's webinar. So before we begin, I would like to acknowledge the traditional custodians of the lands from which we are joining this evening. I'm joining from the lands of Gadigal people of the Eora Nations, and I pay my respects to elders past and present, and extend the respect to all Aboriginal and Torres Strait Islander people joining us tonight, and to the traditional custodians of the land from which each of you is joining. Tonight, we will begin with a short presentation from Dr. Nathaniel Wells on the development and key recommendations of the guide. We will then move into a panel discussion, followed by questions from the audience. Please feel free to submit your questions through the Q&A function or the chat at any time during the webinar. And we have Jubert from ACON will help us monitor the chat room as well. Okay, so it is actually my pleasure to introduce Dr. Nathaniel Wells, or Nathan. Nathan is a research fellow at the Kirby Institute at UNSW Sydney, and his research focuses on the health and well-being of people living with HIV and the experiences of migrant gay and bisexual men assessing and engaging with health services and HIV peer support programs. So, Nathan, I will now hand over to you. Can you share your screen and all
Yeah,
good? Yes,
absolutely.
great.
I'll just assume that it's working. Looks like it's good. Yeah, thanks, Horace, for that introduction. So yeah, as Horace just mentioned, my name's Nathaniel Wells, and I'm a research fellow at the Kirby Institute. And in this presentation, I'll just be sort of introducing the guide and that we developed that focuses on providing inclusive HIV care for overseas born gay, bisexual, and other men who have sex with men. Just echoing Horace as well, I also acknowledge the traditional custodians of the land on which we're all meeting today. For me, that's also the Gadigal people of the Eora Nation, and pay my respects to elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander people who are joining. And also recognise that sovereignty was never ceded, and this was always will be Aboriginal land. And just in the context, I guess, of talking about migration, just also recognising the ongoing processes of colonisation that continue to shape health inequities today, and particularly those around regional and global HIV epidemics. Also, just really want to thank everyone who participated in this project and was generous enough to share their time. Was really, we're all really grateful for it. Also, just a shout out to my co-authors, community peer networks that reviewed these guidelines, and also the clinicians, and also our funders for this guide, which was Vive Healthcare. And I've just put a quick QR code there for anyone. I think there was a link to the guide in the original invitation for this webinar, but there's also a QR code there for anyone, and I'll have it on the last slide as well. So if you don't get a chance to get to it now, it will be repeated. So I guess just to start with some background, many overseas born gay and bisexual men or other men who have sex with men, or GBM, experience increased challenges to engaging with HIV care when compared with some of their Australian-born counterparts. Common barriers include concerns about the impact of HIV on permanent migration opportunities, uncertainty about the confidentiality of medical records, having to navigate what's often an unfamiliar healthcare system, exclusion from Medicare and subsidised health services, anticipated and enacted HIV and LGBTQ plus stigma, and understandings of HIV sometimes as an untreatable health condition. And because of these barriers, some overseas born GBM living with HIV sometimes have heightened challenges of engaging in care and retention in care, and are more likely to initiate treatment later and take longer to reach viral suppression. So with this in mind, we developed a practice guide through a co-design process between ACON, Positive Life, New South Wales and the Kirby Institute, with the aim of the guide was to provide a resource to support clinicians in providing safe and inclusive care to overseas born GBM living with HIV. And as part of this process, we did 4 focus groups, 2 of those with overseas born GBM who are living with HIV, 14 participants in total, and then 2 consultations with HIV service providers, which had 10 participants in total. And those service providers all had a quite extensive experience working with migrant and overseas born GBM. And so then based on these, we drafted a practice guide, which included a set of recommendations and suggestions for clinicians who were providing care to overseas born GBM with HIV. And these recommendations were then sent out for sort of review and feedback by members of 2 community-based HIV peer networks, so PANA, Positive Asian Network Australia, and PLAN, which is the Positive Latinx Australia network. And that was to just really make sure that our recommendations were resonating with community and were relevant. And then that feedback was incorporated, and then a version of the guide was also sent out to a small number of clinicians just to ensure that it was also clinically relevant. So to give you just sort of, I guess, a broad overall sense of it, the guide consists of 12 recommendations that are broadly related to conveying an HIV diagnosis, referrals to peer support, migration services and mental health services and other services, and also the communication of health information. And we also included a series of conversation prompts for the recommendations, and these were developed by individuals with lived experience of both migration and HIV. And these prompts aren't necessarily intended to be prescriptive, and instead they're really just hopefully practical examples of how you might approach different aspects of and conversations in providing HIV care. And so I won't go through all the recommendations tonight, just in the interest of time, but I'll just sort of present on a few that were included that I think are worth highlighting, particularly as they're of real relevance to many overseas born GBM living with HIV. And it's also just to give you a bit of a flavour of the guide itself. So, as many probably know, migration is a really key concern for many people living with HIV, particularly around seeking to attain permanent residency in Australia and the impact of an HIV diagnosis. And some participants indicated that they had assumed that living with HIV would automatically foreclose any opportunity for obtaining Australian permanent residency. And that's something that's repeated in the literature as well and is a really common narrative. And was something that healthcare workers should be aware of. So as one healthcare worker stated, many people, they're dealing with other issues as well as HIV, as well as an HIV diagnosis, whether they'll ever get PR or a visa. As healthcare workers, we need to be aware of that to be really able to support people. And while it was felt that healthcare workers needed to be cognizant and of potential concerns about migration, excuse me, participants living with HIV didn't feel that it was necessarily the place of clinicians to discuss all the specifics of migration, and important to refer to specialist services. As one participant who was living with HIV commented, I think migration is important, not that the doctor tells you all the visa information, but the referral pathways. And when raising potential concerns about migration, it was felt that it should be acknowledged and people be referred to specialist services. And it was also felt that it was important for any discussions about migration to be framed in a positive light, and emphasising that many people do successfully navigate the migration process despite the additional barriers and challenges. And speaking of referrals, peer support was also framed as a really, really important part of HIV care. HIV peer support creates a sense of belonging, offers first-hand experiences of living with HIV, and can enhance treatment adherence and retention in care. And many peer organisations have peers employed who speak multiple languages and or with migration experience as well. And it was recommended that referrals to these peer support programs are made at or very soon after diagnosis. So one participant here stating, the workshops I attended at ACON after that diagnosis, that was very helpful. However, there were others who felt that it might be too overwhelming in those very early stages of diagnosis, as well. As we have another participant here saying, for me, there was definitely a lot going on after being diagnosed. It was too much having that blast of information. And I think for me, at least what this quote highlights is the significance that receiving an HIV diagnosis can have for many people, and that for some, engaging with other services soon after or right after diagnosis can be overwhelming. So it's also important that referrals to peer support make up sort of part of the ongoing HIV care, and not just be siloed into that early stage. And another recommendation that was made was around the communication of medical language, particularly around undetectable viral load. And for some individuals, technical language such as undetectable equals untransmittable or U equals U may not be easily understood, particularly for those for whom English might be a second language. As one participant living with HIV indicated, the doctors said that I'm undetectable, but didn't explain what that means. I had no idea. I knew I was fine physically, but I didn't know what undetectable means really. And it really stood out to me in one of the focus groups when one of the group facilitators sort of asked people the question, so how would you explain that when you have an undetectable viral load, there's no risk of HIV transmission? And without batting an eyelid, one participant just sort of responded straight away and went, well, exactly what you just said. Keep it simple. And so I think it's also critical to emphasize that zero risk aspect in there as well when talking about undetectable viral load, particularly as phrases like negligible or effectively no risk can sow doubt for some people. So given time, I'll leave it there and hope that's just given a bit of a flavour of what the guide includes. I'm sure there'll be more discussion of it with the panel. So yeah, as I said, if anyone would like a copy, please feel free to scan the QR code. I've no doubt that some of the information in there might be sort of familiar or feel intuitive to a lot of people, but I think it's still a really useful resource for healthcare workers who are new to HIV or with more limited experience. But also, I think it's always a good reminder for anyone who's been doing this work for many, many years as well. And just also to say that although the guide is focused specifically on overseas born GBM, I think some of the recommendations made in there also have use in providing HIV care regardless of an individual's migration background. So I'll leave it there, and thanks for letting me present tonight.
Thanks, Nathan. Thank you very much. This is a very helpful overview. And the guide highlights that good HIV care involves more than just like treatment. You talk about like clear communications, like understanding of migration, related concerns, appropriate referral pathway, and access to peer and community support. Um, I would like to now to welcome our panelists. And again, please feel free to submit your questions through the Q&A section function at any time during the panel if you have any question, if you have any comment or feedback. So our first panelist tonight, it's Professor David Lewis. So David is the director of the Western Sydney Sexual Health Centre. He has more than 35 years of clinical research and public health experience in HIV and sexual transmitted infections across the UK, Africa, and Australia. And he holds academic appointments at the University of Sydney, Curtin University, and the University of Cape Town. The next panelist is Diago. So Diago is peer support officer at Positive Life New South Wales. Originally from South America, he brings experience in communications, community health promotion, and also multicultural engagement, with a particular focus on strengthening the voices of overseas-born communities within Australia's HIV responses. And our next panelist is Justin. So Justin is a team leader at ACON, where he has spent the past 7 years delivering peer support programs for people living with HIV and people who use drugs. And we also have Billy. So Billy is a peer and vocational support officer at Positive Life New South Wales, and he provides peer navigation support, social support, and also community engagement programs for people living with HIV across New South Wales. And last but not least, of course, Nathan, you met Nathan, who brings the research and guide development perspectives. So welcome everyone, the panelists, and thank you again, Nathan, for setting the scenes for us. I would now like to start by bringing in the different perspective of tonight to represent it on the panel. So maybe could each of you briefly tell us what brings you to this discussion tonight and what perspective you hope to contribute tonight? Maybe I will start with David yourself. Like, what do you think, David?
Thanks, Horace. Well, I think tonight I'm here primarily to contribute to this discussion from the perspective of a clinician with many years' experience looking after GBM who are living with HIV. And I think also in Australia, through my role with the New South Wales Ministry of Health's HIV support program, where I act as a coordinator for Western Sydney, I've also able to share and understand a little bit about what it's like for GPs having to give diagnoses often for the first time to patients in our area, where we really don't have many S100 or GPs that can prescribe HIV medication. And I think also another unique feature from my perspective is that we have peer navigators from Positive Life New South Wales embedded within our service on Thursday nights. And I've also had the opportunity to witness that firsthand from the reaction of patients, the incredible support and confidence that these peer navigators can give to them, either at the start of their journey or in journeys that have been going on a long time, but for which they've really suffered for years due to impact of stigma. And we've also seen benefit, obviously, from other referrals out to programs like ACON and Bobby Goldsmith Foundation. So I think it's important to make sure that clinicians do utilize what's available. And I think tonight just brings it all together about improving clinical practice around patient care. And I'm delighted to be here to support the launch of this very important document.
Thanks, David. We have a very diverse audience as well. Can you explain a little bit what does that mean by S100 prescriber in case someone in the audience
Sure.
would know? Yeah.
So the way it works in Australia is that basically if you want to prescribe certain drugs, including HIV medications, you have to be a licensed S100 prescriber. That's the terminology that's used for the type of drug that's being prescribed. And so GPs would have to go on a course, usually run by ASHM, to get that. Now, there are a lot of them in the CBD, a lot of these GPs, so it's very easy for patients to find GPs, but in our part of Western Sydney, we've only got 4 or 5 maximum in the whole district of over 1 million people. So it means that patients do need to come to the hospital or to for either infectious disease inpatients, or in case of Liverpool, it would be immunology, or else to the sexual health services. So it does limit access and for some people.
Thanks very much, David. That will be something that we can also talk about later tonight about the geographical differences among Sydney, because Sydney is so diverse as well. Okay, so the next person I would like to ask will be Diago. So Diago, what brings you here tonight and what perspective you hope to contribute tonight? Yep.
Hi everyone. Yeah, thanks. Hi everyone. I'm Diego. I work at Positive Life, and I migrated to Australia around 2019, and then I was involved with ACON as a client, and then as a volunteer, and then as a peer. So I have kind of experienced the system from outside and inside, and have been surrounded by amazing, inspiring professional people who also have shared their knowledge with me. And throughout the years, talking precisely with people from Plan, with Positive Latinos, Latin American network, and from PANA, the Asian version of that one, both from NAPWA. In some of those networks, we have people that actually works at QPP, to Positive Life Victoria, and Positive Life New South Wales. So there's a lot of knowledge there, and always the conversation was around the same topics and why no one is addressing these topics, pretty much. And then when we were having this discussion back in ACON with Jack Freeston, who started also this, and hello to him, hopefully he's online, was pretty much that gap, that there was nothing that, and here it goes. This is kind of a thought, not for someone like David, but for someone that is around David, someone like a new doctor, a new nurse that is new to the sector and that wants to do the best, at the best intention, have the professional clinical side very well established, but then they are confronted with called overseas born people living with HIV, and they don't know what to say or what to do because of their lack of exposure to this population. And then literally that this project is always been thought for that audience, for them to have some tools, because basically in Australia have amazing clinical tools. We all know how privileged we are to have all the clinical support here around HIV care, but then that little gap, and it's very generic, very clinical. So when someone wanted to say something to this population, they didn't have a lot of resources around this that they can usually access. Not something that practical, and that was what we brought into this project. That's what hopefully we'll bring into also this panel.
Yes. Thanks very much, Diego. And then the next one, I will ask Justin. So can you tell us like what brings you here tonight? What kind of perspective you like to contribute to the conversation?
Thanks, Horace. I'm here tonight because I was asked to come here tonight. But more than that, I came to Australia at the age of 19 as a migrant from mainland China. Within 2 years, I received my HIV diagnosis. And then 2 months after that, I started to use crystal meth. So I think HIV was such a huge thing over my head at the time because it really changed the way I perceive myself as a person. I didn't go through the whole immigration process because I was lucky that I had my residency before I had my HIV. But when I work with peers in the community, I really see how a manageable chronic disease today still impacts people in a way that they just don't believe they can live the life that they ever imagined. And I think the mental health side of things, like the impact of HIV to chemsex and other forms of drug use, is, where my interest lies these days. And yeah, and that's why I'm here.
Thanks, Justin. Thanks for your sharing. And also, I think that's also speak to why this guy is so important, because sometimes like doctors and nurses can either support the person who diagnosed HIV or actually unintentionally induce harm to the person if they do not know how to work with the person who diagnosed with HIV. And then next will be Billy. So hi, Billy. Can you tell us more about what perspective you hope to contribute tonight?
Hello. I think I'm echoing what Dr. David and Diego have said as well. Like with Dr. David, I happen to be one of those who are stationed in the clinic as a peer navigator. So like being able to like see like people who have been like referred early on into a social support, and for those who come later on throughout their HIV journey, for example, we can actually see the distinctions. And then like if we are talking about the migrations in particular for this one, for example, like having the knowledge early on compared to the knowledge later might have a very different impacts on somebody's journey, right? I've seen somebody firsthand with a skilled, he given time, if there is enough time for preparations or not, the knowledge come early on, that person can actually get his permanent residency easily. But because of the HIV diagnosis, and then without knowing that, oh, living with HIV does have implications on the visa options and this and that, and then with the clinicians assuming that, oh, this person is well educated, has a PhD, he must have known. And having to see and say goodbye to that person leaving Australia because there's no more other visa pathways, realizing too late, 1 month, 2 months before the expiry of the visa. So I think hopefully during these discussions, I think I will be able to provide the real life example through the work at Positive Life that we have seen, or my colleague have seen here as well. So
definitely,
that's it.
Yeah, thanks very much, Billy. And last but not least, Nathan, you just had a presentation, of course, but what kind of things you would also like to contribute to tonight's conversation? You're on mute.
Very, very much echoing other people as well. Really just wanting to, I guess, provide maybe a bit of the research perspective and background that went into this as well. And yeah, sort of, situate it around there.
Right. Thanks. So we have a very experienced panel and diverse panel with a range of experience and perspective represented here tonight. So I would like to actually turn to the questions about what people may experience after receiving an HIV diagnosis. I just didn't touch on this, but I would like to ask David and Diego first. Like, from your clinical and peer support perspectives, what are some of the most common concerns or maybe fears you see among recent migrants or people living on temporary visas? David, would you like to start first?
Sure, Horace. Well, I think the first thing to say really is at the time of diagnosis, reactions vary so much, and it's really important for clinicians to respond to the non-verbal cues that come from the patient in front of them. Some of the patients just want to cry. Others are too emotional to take it in at the first consult. Others are very pragmatic and just want to get onto treatment and get out of the clinic as quickly as possible. And there are some patients who just don't want to say anything at all. And in my own experience, as long as I've had to sit in silence with somebody is almost 30 minutes. Now that's very hard for a clinician to do. And I notice it's recommendation number one, and it really should be there. Number one, allow people time to process. You just have to wait until people are ready to talk, but make them also feel comfortable. It's okay to be silent and to think. And as a clinician, I often sit and think, well, what's going through that person's head? What are they thinking about? And sometimes things will come out like the shame, what am I going to tell my family? What am I going to tell my friends, my partner, and for some people, my children? And I think our job as clinicians is not just to look after people medically, but we have to offer hope and encouragement. And clinicians of my generation really remember when we didn't have much to offer. I'm talking about, I was from the era where we just had AZT, right? So I remember the really bad days. Lots of people were dying, but now we have so much to offer. We have these single dose treatments, easy to take tablets, or if you want injections every 2 months, you can do that as well. And also we've got confidence now from research to explain about U equals U, undetectable is untransmittable, and talking about zero transmission, so that people can have fulfilled sexual lives without fear of infecting partners and loved ones. And I think the other thing, Horace, is, as someone who's also migrated, first of all, from the UK to South Africa, which wasn't easy, and then again to Australia, I've been personally impacted by the lengthy processes that exist. And therefore, I always make it a big point of discussing this at the very beginning, because for me, if you can remove that barrier at visit one by explaining there are specialists like Hauk who are around to provide the support, and that they will be supported. And it may just be, as Nathan said, a temporary increase in the amount of time till they get through, but most people do get through in my experience. So, really offering that and removing that barrier is very important in day one. And I think, a lot of patients have different perceptions on what an HIV diagnosis means. Many have got partners and friends who are already living with HIV, so they understand something. But there are others who come and still asking in 2026, can I share my teacup or my knife and fork with my friends? So never assume. I think we really need to understand what the patient understands, and that's probably the most important thing. As you learn to get to know that patient, you get to know them more over time, but you've got to keep checking in to make sure that they are understanding where things are at, and that you understand as a caregiver what perceptions are there that really need some, I guess, more health education around. And this is where the nurses, social workers, peer educators, they can all have a big role to play.
Yes, thanks, David. Yeah, totally. I think what you mentioned very importantly, like using like therapeutic communication skills, really spend time with the people and understand their perspective. Diego, what do you think from a peer support perspective? What are some of the most common concerns that you've encountered?
I think following what David says, it's just like when people describe they're about to die in an accident, they see all their life through their eyes in a second. That's pretty much a good picture of what's going through usually people's mind when they receive a diagnosis, and especially coming from countries different to Australia, of course, but that has a healthcare system that are not that strong, and they still relying on all information. Sometimes they have heard from friends with HIV in their countries how the experience is getting medications, and they think is going to be the same here. So they are coming with those glasses, with the magnifiers glasses, with all the stigma solely on the condition itself and also on the healthcare system. So sometimes you have to understand that even though you have in this position of authority as a doctor, they might have had awful experiences in the past with doctors for other topics. So whatever you say might not be what they might not be listening to you. And then after all of that, of course, immediately is my future is done. I don't have any future. And then on top of that, I have to see how I'm going to stay in this country. I was even struggling to pay a student visa. That was kind of like a pathway. Now I have this, so now it's going to be impossible. Before it was hard, now it's impossible, which becomes over time the permanent stressor all over the time they need to process this. So basically is those two things: the stigma that they come from the lack of information and concerns about the visa.
Yeah. Speaking of visa, actually, I think a lot of us probably in the audience wouldn't know, like the questions will be, is someone diagnosed with HIV, can they stay in Australia? What's the visa process? Are they have to like got deported or anything like that? Can maybe any of the panelists can explain a little bit about the process if someone got diagnosed with HIV, what would happen? They got deported or what would happen? Yeah. David, would you like to answer this question, or Diego, or anyone?
Tim Billy will be.
Yeah.
Okay,
This
great.
is my
Billy.
passions actually.
Okay. Great.
I mean, again, like from my accent, like most of you will probably knows, right? Like I was not born here in Australia, so having to go through that process myself, and then having seen a lot of community member going through that process. So like with full disclaimer here, like this is not a legal advice. I'm not a migration agent, not a migration professional. Like this is not a migration advice. This is just based on the information or the knowledge I got from talking to community member. Like so, like with HIV diagnosis does come with, because like HIV diagnosis is a medical diagnosis, and then every Australian visa does come with a health requirement. So like, and then apparently one of the things that they tested for in part of their health requirements is HIV. And then because HIV care is quite expensive. I think they're costing it around $1,200 to $2,000 a month. So like Australian government do put a threshold that if your care exceeding at the moment it's 81,000 for the durations of your visa, then you will fail that health criteria. So like so back to your questions there, then like with if I am diagnosed with HIV, for example, am I going is it going to impact my visas? Then that question will go down to like what visas that I have at the moment. Do I have any plan to apply for visas anytime soon? And then what kind of pathways do I want to go through? You know, like either I'm going to study on the graduate visas, skill visas later on, and then permanent residency. So I think this is where early knowledge, so like talking to HUB, for example, talking to migration agents that is familiar with HIV, health waiver, HIV processes is very important so that you gain like, so you're not investing your time, energy, and money into a pathways that you know that is not going to work. There's a way around it, but again, that will really depend on your situations.
Thanks, Bailey. Okay, so what we have been hearing is that like people's concern after the diagnosis often extend well beyond the medical diagnosis. So thinking about the things like stigma, thinking about like migration, everything adding up together. So that's now I would like to ask Justin and Billy as well, like to bring you in the conversation here. So what can peer support provide that even a very supportive healthcare professional may not be able to provide? So what's the uniqueness of peer support here?
Sure.
Justin, yeah.
Yeah, I think when we work with this particular population, we must remember that they are overseas-born migrants first. What that means is they have understood the world in a different culture, in a different way. So things like U equals U, the message can be translated to other languages, but it may not make sense in their cultural understanding. The Chinese language is kind of is a good example. So the message of U equals U makes sense as a sentence. It doesn't go into people's mind as a belief, because the moment you hear HIV, actually in the Chinese context, if you hear HIV, you just call it the AIDS virus. So to tell me I have AIDS virus, but I can't pass it, doesn't make sense on an emotional level either. And I guess that's just one of the examples of providing peer support to people with lived experience of being, have migrated or, lived abroad, that whenever we provide care under, the medical care kind of umbrella, there's actually a lot we need to consider. Often is, more than just prescribing the medication and checking the bloods. In my particular area of work, the work I do these days is purely focused on sexualized drug use or chemsex, if you like. And we see a lot of, I guess, overseas-born gay and bisexual men, and the way they present to our service is quite different. You will find people who are similar age, who are diagnosed around a similar time, but have a much better outcome or much easier process understanding their diagnosis. And I've always wondered why that is the case. And often, if we really look into their lives, that's because HIV became a barrier for them to become the person they want to be. In some instances, like many people have talked about tonight, if you don't have a visa in the country that you want to stay in, it can become a huge barrier. You don't know how to answer your family. You don't know how to answer your friends or even yourself. You've let yourself down. I also see a lot of, I guess, overseas-born gay and bisexual men who thought they've dealt with their diagnosis for years. They've been undetectable for like 10, 20 years. Well, maybe not 20, like 10, 12 years. But they've never talked about it. They don't know what it means. Nobody knows. And they feel this huge hole in their heart. and drug use can happen, staying in toxic relationships, a lot of other things can happen, but we really trace it back, it's due to the HIV. That's the one thing that is too painful to deal with. Coming to terms as an HIV positive person is still somehow difficult, and therefore by wanting to avoid or escape from the causing problem, and they hide under that drug use kind of scene. So this is a very common presentation as well for me. I think I've just been talking. I forgot your question. What was your
So
question?
kind of like that's interesting. Yeah, that's a very good kind of experience sharing. So what can peer support provide that even provide
Yes,
that provide to
yes,
to
peer support.
peer support
Yeah,
to you?
I think it's definitely around the shared experience. Like all services these days, in Australia or in any Western countries, you will see, like, what the service will say is, oh, we are a safe space. But what is a safe space? It's not a space with a rainbow sticker. That's not a safe space. A safe space is when I disclose something that's really close to my heart and I'm ashamed of. You don't judge me. That's how you build trust as a clinician or a service provider and your client. You can't just expect people to trust you because you've told them you can trust me. That's not quite how it works. So I think peers did peer identity really kind of eliminate that barrier because you too have HIV. And I think this is, like something really magical about working as a peer worker is that, stigma, discrimination, fear, all these huge topics can be really challenging to deal with if you are a service provider. But in the space of peer, whenever you hold a group of people together under the same name, those barriers just break down it by itself. I think, like this whole thing of I have HIV, me too. I use drugs, me too. And I think that's, what really tackles the issues of isolation and, all of those things.
Yeah.
Yeah.
Thanks, Justin. The other, you just put over your hand. What do you want to add?
Yeah, I use following up what Justin says, which is very on point. Is basically I remember a clinician asked me that, and it's basically whatever you say in the room for the patient to imagine how their life could be. You're pretty much showing them, right? The peer can show usually peers without one, and it becomes role models or pathway that they can end up being. So is passing from the theory that a doctor with the best intentions can tell them in a consultation room to the reality, to the practice, to what I can get. I did this. Another community member like you did that and had that, and then they did that. So you are giving them a lot of practical tips for them to navigate this, and that is valuable for many other topics outside the clinical one, because the less we don't talk about any clinical thing that's maybe in the beginning, but we also offer them, we also are like the best supporters of the other parts of the chain. It's like, I don't like my doctor because I'm like, maybe a doctor wanted to say this and that, and they're like, oh, or I don't like I don't want something that makes a huge difference in someone that is just recently diagnosed, is when they come from cultural linguistic background places where mental health has its own stigma. So it's like, I'm not going to mental health, I'm not going to a counselor just because the doctor told me. But then when a peer tells them like, yes, but it helped me with this and that, I'm like, so it's not because I'm crazy. Right, because that's the concept they brought from their countries of origin. And yet again, doctors is like the father telling you things, but then peers is like the friend who say, but maybe your dad is right in this, can you try it? And then that make easier whatever the doctor has tried to do in the consultation room.
So there are lots of like insider knowledge, or kind of like people don't have to explain a lot. So when they see you, they know that okay, you will understand. I don't have to explain everything from the very beginning. Billy, what do you think? Billy, do you have any kind of experience in sharing through your peer navigator work, support work? Any things you can share with us?
I think like just echoing what both Justin and Diego has said. I think it's like peer navigation is all about like share experience, but at the same time as well, there's a wraparound services there, right? Like so, like role modeling is part of that service. Referral, for example, like because like you have worked with community members often, you know that which services is the best suited for the person. For example, if this person's need, let's say, mental health referral, like where is the best for this particular person, because like what we want in the end of the day is that to look in, I'm going to use interchange patient and community members, but looking at the patients as a human, looking at the community members as a human as a whole, you know, like they're not just a random statistics, or there's Mr. Billy down the road they get tested positive for HIV, you know, like it's much more than that. There's there's somebody's son, somebody's friend, somebody's daughter, you know, like so what we really want is that to create that positive reinforcement through like connections, through rapport building, through trust, so that you know, like there's this connection sometimes from the brain and emotional. And then what I like to use is actually peer will be able to connect the disconnect between emotional and then intelligence, like understanding, and like intelligence wise, like you understand that I'm not going to die from HIV, but looking at the scenario at the moment, you know, like in the grounds here, like Dr. David can vouch for this, is that clinically they are good, but mentally they are not. You know, like so which one is worse? You know, like HIV will not kill you, but your mental health and your social isolation is the one's going to kill you. You know, you're slowly withdrawing from life. This is where the peer navigations can help as well, in terms of like connecting you with the community, so that you know you're not alone. If you walk down George Street in the middle of Sydney CBD, like you don't know which one is positive, which one is not. You know, like but when you see somebody in the room full of the people, that you know that they all look the same like me, like why all this time I feel alone, you know, yeah.
I think a very strong message coming here is that the role of peer, not only kind of like providing the insider understanding, you do not have to explain everything. It's also kind of helping that what we call the person-centered practice. Because we are seeing the person is not only the biomedical side, it's not only kind of like your diagnosis, the treatment, but that bring kind of like, as Bailey just mentioned, like the person is someone's daughter, someone's kind of like son, they have their own values, they have their own lives. And the peer have a very important role here to maintain that peer, that person-centered practice. And more practically, I just like to ask, like probably maybe David or Diego or anyone can share with that. So how can clinicians connect someone with peer support in a way that feels respectful? So maybe David, how have you been like you connect the people, the person just diagnosed with peer support? Oh, you're on mute.
I was so enjoying listening to Justin and Billy. Yeah, I think the most important thing is at the beginning that you explain what peer support is in relatively simple language. So before you ask anything more, so the person knows what you're asking about. As I said, we're lucky on Thursday nights at our centre. We have Billy present, but you know, for many practices there isn't someone, but you know they're easily available for connection. So I think clinicians and services have a responsibility to get to know the community groups, get people to come and talk about what services are on offer. You know, we've had ACON come tell us about all their various offerings in Bobby Goldsmith and so forth. So get to know that, make the connections, the professional connections, because peer navigators are professionals as well. And I think that, you know, it's important that, you know, clinicians, nurses, we understand that, and we're all working to look at different aspects of making the body whole. Yep. So yeah, and I think that usually I offer, would that help? And if I see a lot of reticence, I might then give an example, abstract example, though I've seen it work very well for other people. And then, maybe this is something you might want to think about. We'll talk about it another time. I usually will give the phone number of the organization and the website, and I make sure that they can take that away in case they want to discuss or with friends or maybe think about it in between appointments. So there are various things you can do, but don't just do it once. I think it's got to be a repetitive process.
Yeah, especially like for someone probably if they're new migrant, they're not very familiar with the peer support. They may, and also all the fears about the stigma, they may just don't want to talk to other people at the very beginning as well.
Yes.
Yeah, and maybe can I ask like Billy and Diago, like how other than like for example like a community GP, how they can get connected to New South Wales Positive Life, how they can get like refer their patient to peer support.
So in the guide, like I'm selling it, you cannot see it, but in the guide, that's why we make sure we put in various early steps, they offer peer support early, but we also say not just early, throughout the whole HIV care, because some people don't want to see anyone for months, especially from their own culture. Like, I don't want to see another South American because they will be gossipy. Da, 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 da. With time, the doctor is like, yes, but I think that we have from other cultures, whatever suits you, and then down the road, the person will say yes, right? And once they say yes, the value of the peer is that we will reinforce whatever the doctor says. And then if you go to the guide have QR codes that will take you, for example, to the NAPWA website, where is all the national organizations such as Positive Life, such as ACON, such as BGF, such as Positive Life Victoria are listed. So anyone in the country, if you go to the guide and scan that QR code, you will get there, and then you will get the basic information you need to contact them. Even if you don't know anyone from there, even if you are very new to the sector and there's no one around like Dr. David to tell you, call Billy, you can just call the contact number of these organizations based on where you are, and they will definitely say, absolutely, this is our email, and that's kind of it. Of course, you need to have other actions in place to make sure everything is following a protocol, but at least from that website in NAPWA, you can find the official places where you can get support.
Yeah. So
as a
basically,
clinician.
yeah. So basically, clinician can refer their patient, their service users to these services, and also people living with HIV, diagnosed with HIV, they can also refer them to and contact your organization. Great. Someone just mentioned in the chat room about trauma-informed care. I think it's a very important ways like recognizing trauma. Just wondering the panel, what do you think about trauma-informed care? How did you use trauma-informed care in your practice? Incorporate that, recognizing people's trauma. Justin, would you like to start? Yeah, because probably you handle a lot of like and
because
I
I look
encounter a
like
lot of
trauma.
people. You don't look like that. I don't know
Oh,
what you've
God.
been through, but a trauma-informed practice is like recognizing trauma is so common. So, but I'm
Look,
sure that in your work you have been encounter a lot of people who encounter trauma. So how you
yes.
incorporate trauma in your work?
Yes, thanks, Horace. Trauma-informed care, and I guess the general term trauma has been very, I guess, commonly and sometimes even loosely used in our sectors. I think often we don't really understand if we were going to provide trauma-informed care, what does it mean? Like, what do we need to do? And I talk about this in a like from the perspective where I guess I've received really trauma-informed care myself. Uh, but there have been times when I'm in practice of my peer work, I've kind of had to reflect on my own practice and ask myself, was that trauma-informed enough? So, like I think we really need to kind of understand whether you are a doctor, a nurse, a psychologist, or you're a peer worker, the moment we step into a room, there is a power dynamic. Naturally, there is a power dynamic. And as care provider, we are always on the top of that power dynamic. So what that means is with trauma-informed care, I believe is just to not judge people's views, but instead challenge their thinking process. I think there have been times when my client told me a narrative that clearly sounds like um, not scientific or not correct or morally even a bit questionable. But I had to refrain myself from asking questions. Well, no, sorry, refrain myself from pointing that out or just, disagreeing. Instead, I would ask questions to understand why they have such views.
Yep.
I think being trauma informed at the end of the day means that we are on people's side. Even though we might not personally agree with their view or opinion, we're trying to understand and we're trying to encourage the clients to come to a decision that feels right for them. Obviously, they must sit under our professional guidelines as well, right? And I think that's quite different between a peer and a GP. But the ethos of trauma-informed care lays there.
Yeah, thanks. I think what you mentioned really resonate to it. It's about the power differences. I think all trauma-informed care had to recognize the power dynamics between the healthcare workers and also the patient, especially like the person just diagnosed with HIV. They're from like a new country. They just migrated to Australia, for example. There are lots of like things in play in their life, and probably the power difference will be very, very kind of like steep between the clinicians and also the patient. Nathan, we've been quiet. Just wanted to touch base on this about trauma-informed care. In your study, did you talk about trauma, and anyone mentioned about this, or how to provide create a safe space for the participant, for the patient?
Yeah, I think a lot of it goes back to what Bo Justin was just saying earlier about asking a lot of questions. No, I mean, not too many questions. You don't want to completely overburden someone. But yeah, asking questions in a way that lets people know that you're on their side, that you've got them, that things will be okay. And also, I guess, because we in the guide we talk about that a lot of this is framed around patient-centered or person-centered approaches to care. And so it's really getting to know where an individual's at as well, and just really understand what's going on for them beyond just a medical diagnosis.
Yes, thanks. Yeah, thanks, Nathan. Thanks, Hannah, putting in the chat room talking about trauma-informed care, kind of like the principle of trauma-informed care. So trauma-informed care recognizes the impact of stigma, discrimination, and past experiences, and prioritizes safety, trust, choice of the person, collaboration, and also empowerment to support the health and well-being of people living with HIV. So trauma-informed care not only working with people in HIV, it's like working with, for example, in migrant space, sometimes like they may from a refugee background as well, like kind of like other backgrounds. So trauma, it's actually quite common among the population. Then I would like to move on to the next question, a more practical questions to ask everyone. So what is one common mistakes that a well-intentioned healthcare professional may make when supporting someone newly diagnosed with HIV, according to your experience? What common mistake you have seen? So I would like to hear from all of you on this. So who would like to start first? David?
Yeah, sure.
Yeah,
Yeah, I'm happy
you're
to do that.
experienced clinician. Yeah. So what kind
Yes.
of like mistake you've seen?
Well, I think there's probably the most common mistake really is not checking in enough with patients about what they understand. And it's important to keep checking in that you've understood information shared with them. And that's like really busy when you're in certainly in general practice where you are very time limited. In sexual health services, we still have half an hour, but we have to do the blood test, the vaccinations, and everything else. That often the bit that gets left out or squeezed is this bit about listening to people And very important to avoid jargon. You see, I've already used jargon tonight with S100. So, I mean, just to give you an example, it's very easy for clinicians. We'll move into these things, talk about ARVs, viral loads, U equals U, and just not explain. And maybe have a thing that everybody understands this because we understand it, and it's not the case. So, yeah, I think that's probably for me the most common thing in clinical practice.
Thanks, David. Diago, do you have any experience about you have seen people committed mistakes when they engage with people just diagnosed with HIV? What kind of mistakes have you ever seen?
Yeah, the mistakes were the one that informed the steps, pretty much. Basically, what comes to my mind is yet again, even though you have seen the patient for a while now, for a couple of weeks or even months, assuming they already understood some topics that are sensitive for this population, like yet again, the medical ones are actually the easier and the quicker for them to understand and internalize, right? So it's like, I know it's your area of expertise, but you can pause on that and then move on to other topics down the road, such as confidentiality, for example. I remember confidentiality is very different. What we think is not all your information is private, and that's all they say. No, it's protected. That's not enough, because they come from a country where the doctors say that, and then they brought their mother into the room, or
Yes.
they shared that information between agencies that shouldn't be. So they are not going to believe you just because you say that, right? So you have to say, we don't share this with migration at all. That's not going to happen. And if we get to do it, we will have to ask you specifically. Another one is, a big one is also assuming that the patient, even though has been with them for a while, already understand the healthcare system in Australia, which is very complex. I still don't understand, and I've been here 7 years. So I always give the same example, and this group must be tired of hearing the same example. It's like just starting with the word GP. I'm like, what the hell is that? Like, they go to the GP. What's a GP? Or S100 or Medicare. Without Medicare, like it's like you can go even if you don't have Medicare. I'm like, you know what I mean? So assuming that because the patient has been with you for a while, that they understand, and all comes down to ask them, do you understand what I told you? Because sometimes you don't want to kind of make them feel uncomfortable by asking them, like maybe the patient will think that I'm telling them that they don't speak proper English or whatever. No, just ask and re-ask. And yet again, this is for kind of new doctors that might be a little bit cautious, especially if they are not overseas born. So ask them and make sure. I think those are the main ones.
Yeah. I think what you just mentioned is really tied into what Hannah shared, I think, earlier about trauma-informed care, about how the confidentiality is about safety. It's also about providing choice and collaboration. And what you mentioned really speak to my own experience as well. So I'm a migrant and came here like 11 years ago. And then when I first came, I'm a healthcare worker, but people talk about like bulk billing. What does that mean, bulk billing? And where can I get my medication? I'm like, okay, so even though I've kind of like educated healthcare workers before I came to this country, it's also I find it very confusing. And imagine someone's like who don't have health medical background, that will even further more confusing. And actually, I also have one kind of like experience in kind of common mistake in practice. I've seen some kind of like clinicians after the person's diagnosed with HIV, they ask a lot of questions. They try to find out like a detective, like why did you get HIV? Rather than focusing on the person experience, they just keep asking like how did you get it? When did you have sex? Like did you have sex with men and women? Forgetting about actually all the things, the overwhelming of the person at that time. So that's something that also seen in my practice as well. Billy and Justice, do you have any thoughts about this?
I think another one, like to follow on that topic as well. Sometimes we don't know when, right? And I mean, there's two type of questions. I think it's also linked to what Hannah said. Like the question that you ask, is it like for your curiosity or for the benefit of the patients? Like sometimes we ask nosy questions because we are nosy, or we are putting it in a very medical way. You know, like that it sounds like it's for the benefit of them, but it's just because you're curious.
Hmm.
Like, and then it's very important to have these biases and realize these biases that we had as well. And like in the end of the day, you are here for the health benefit of the person in front of you, not to satisfy your gossip level engagement. Another thing as well is that I have seen happen a lot is that because HIV is such a big topic, right? It's such a heavy topic. A lot of the doctor, they need another support if they do have to deliver it for the first time. And consequences, like unintentionally, it makes the person like so that you're putting it in a way or you're wrapping it in a lot of this layer. So you're trying to wrap it with this gift layer, that gift layer, and then you're just instilling that stigma in
Mm.
itself. Like sometimes being direct is the clearest way or the easiest way. You as the first person that telling the patient in front of you that, hey, you have been diagnosed with HIV. Okay, you're going to be fine. Like there's nothing wrong. It is manageable. Like, or like you are trying to beat around the bush, going around the circle, and then in the end of the day, you're just instilling that stigma again.
Mm.
And I think that's another thing that I want to add on.
Yes. Stigma.
And sorry to interrupt, but what Billy
No,
said
yeah.
is too good not to follow up in terms of running around the bush. And the best topic to talk about that is migration. It's like,
Mm.
and and rightly so, because they don't know about it, so they rather avoid it. And it's like, that's for a lawyer, that's for the community organizations, and it is in a way. But what we were trying to tell the clinicians with this guide is like, but you do have to address it. You cannot avoid it. You don't have to say about visa X or Y, but just ask the question and say, have you the fact that you just know that you have to advise them to get advice early, that's enough. But address it is like, and it's possible to stay in this country. Many people does it. Those kind of quotes and prompts that we put in the guide is because we as peer have been hearing from our community members that the doctor never told me that in a year, like literally. And then unlike that patient wasted a year that could have been doing actions, taking actions, volunteering to get ready for a pathway. And it because that until a year after started HIV care, the patient was in the right mental state to say yes to a peer. It took it took him or her or them a year to hear something about migration. Like, and we are like, what? So you wasted a year of not doing anything. And that's a big mistake because they don't want to talk about anything because they don't have the information. Yet again, that's why we spoke to her 1,000 times, and then we hold the HIV and Legal Aid Center that it's in New South Wales, but provide the services around the country. The only one that provides those services for people with HIV. They were we asked them like how many people go successfully, and they're like the majority of people if they do the process right. And then like, well, doctors need to know this because they cannot be saying like it's hard. Okay, let's go back to Dovato and Biktarvy. It's hard, but no. Let's just not talk about medications and let's maybe. But now they have a resource that they can blame. Like, well, I read it there. It means like, you know what I mean. So that's a common mistake that we are trying to address.
Yes, totally. So a lot of people just focusing on the medical side, forget about what pressing issues from the perspective of the person. And what really the guys bring in, it's about how we can start talking the conversation. Because sometimes I just ask one question can change a person's life. And a lot of healthcare workers, actually, they don't know how to ask that question. And this guy really can show them this is some of the way that you can incorporate in your consultation. Just try to ask that question. So this is the sample. And then you can change someone's life. Maybe just that simple. Yes. So we are going to move to the final question before we go to address some kind of anonymous question in the chat room. So Justin, but do you have any things to add on the mistake that you would like to add on before we move on to the last question?
I think intellectual boundary is the one thing that comes to my mind. And I'm not saying clinicians are not intellectual. In fact, like clinicians are some of the most, like the smartest people, right? Like you're supposed to be. But I think just because you're a doctor, it doesn't mean you have to understand everything. You don't need to understand how did I, what did I need to do to survive as a gay Muslim Chinese person? Like you don't have to understand that. But I think the willingness to start conversation, to show care, to connect me to community organizations, to give me this sense of hope that I might be able to exist as my whole self. I think that's the challenge here in those consultation rooms. Sometimes with clinicians, I find, well, I guess because you have this social status that you're supposed to be, the caregiver, the problem solver. Um, like it doesn't feel good to say no. But nobody can know everything, right? So when to say no is also, I guess, something that everyone needs to learn. Doesn't matter what discipline of your practice is.
Yeah, totally. I think what you mentioned is also really speak to what we call the person-centered practice theories, is that the clinician need to first reflect on their knowledge and also reflect on their biases before engaging with the person and recognize that the person is there. It's kind of like the knowledge of their life. It's about like recognizing lay knowledge. Lay knowledge is also like lived experience. It's also as important as medical knowledge. So let's move to the final question before we can address some of the questions in the chat room. Maybe that question I think I would just ask Nathan first and then ask the rest of the panel. So you mentioned at the very beginning that this guide was developed specifically for overseas-born GB gay and bisexual men, and but many of these principles can be maybe relevant to other communities. So could you give some example, maybe one example of how the guide may be applied to people like women, transgender and gender diverse people, or other overseas-born people living with HIV?
Yeah, good question. I had an answer for this in my head earlier and it's gone completely out of it, which is great timing. But I think some of the things that when we were doing the guide and sort of looking at people's responses and the data and developing some of the recommendations in there, it made me think right back to a project I worked on a few years ago that was looking at people who had recently received an HIV diagnosis. And there were people in there that were saying very similar things to some of the participants in this study. Things like having no comprehension of what U equals U is, not being aware of current HIV treatments. And some of these were people that were very connected to gay communities as well, where you think that the knowledge there would be a little bit more. And I think the principles in there are just kind of just using that person-centered approach is sort of one of the underpinning principles. And so I think that can kind of inform any kind of care. So yeah, I hope that answers your question.
Nathan. And David, would you like to add on how would you say you can use this guide to when you're working with other different populations other than gay bisexual men? You're on mute.
I wasn't involved in the writing of it, so I had the liberty, I guess, of reading it from scratch and from outside. And when I read through it, I remember talking to the guys on this call. It's for me, I just thought this applies to everybody living with HIV. All 12 recommendations. I think they're all equally important. For some people, one or two of them might be more important than others. It very much varies on the person, what's happening in your life. But yeah, I think that they're all really useful, and the amount of information that's in there has been beautifully written, put together, and I really like the fact we've got also those prompts of how you could think about asking questions better. I think as well, one thing I noticed with the GPs I work with at the time of giving the diagnosis through the coordinating role that I do is when I ask the GP, what was the reason the patient wanted the HIV test in the first place, they often don't know. They just did it because they were asked to do it. So they don't know they're gay, bisexual men or whatever else is going on in their life. And you know, that's a lot to actually then to try and work out on day one when you get them back for the results. So I think you know, I think if there's to add anything to this book, it would be a little bit more about questions about how to get that information before you give the results. So at the time someone comes for a test, find out a little bit more so you're a bit better prepared to manage the result when you can. But yeah, no, I think all 12 very, very important recommendations.
Thanks very much. Okay, so these are actually basically all my questions to the panelists. Then let's look at the chat rooms. We have like 2 or 3 questions from the audience. So we have a questions, what strategies can we use to engage with community members who are less engaged and discreet, and particularly with when discussing sexual health in culturally and religiously sensitive contexts? Anyone would like to answer this question? Any insights that you can share?
I
Yes, Billy.
that might be the easiest one if you start first. Before people start taking all the points. I think one point that is very important in terms of the sexual health is that oftentimes like our campaign or the way that we talk about sexual health is that we are packaging it in a way that we are promoting safe free sex. Okay, like so there is these 2 different culture or ways of people approaching sex, right? Like sex is part of their marriage, and then sex as part of their lifestyle. You know, like there's that 2 different things, and then oftentimes all this campaign or all these like brochures that you got, you see a lot of them like again, I came from a Muslim country. My family is all traditional as well. There's no such thing as a free sex, you know, like, but if I do go to, let's say, that Fair Day or any like activations, I feel that I'm being taught to embrace that free sex kind of like idea. I think this is where I mean like in terms of talking about sexual health is very important. But the way that we package it is also very important as well. Like packaging as probably like what we have done with international students, for example, it's part of your health. Or for a lot of straight men, like heterosexual men, you can package it maybe like protecting your partner, protecting other people, because that's what the way they respond to health. For example, like you're not going to get a heterosexual man going for a medical care. But the moment that you package it as that, oh, this like to protect your kids, to protect your partner, they are more likely to engage that one as well. And also a perception of risk as well that like HIV has been predominantly discussed as a gay disease. Like it has been that way as part of the conversations. While worldwide there's more women actually living with HIV than men. Right, that's what. So there's this disconnect, you know, like, oh, if you're tested positive for HIV, you're gay. Like that assumption straight on, you know, like which translate to the knowledge in the street that, like, why do I need to test for HIV? I'm not gay. And how do we change that one, or maybe like blanketed everything instead of opt-out testing. No, instead of opt-in testing, we do an opt-out testing as part of the general health. Maybe, you know, like there's a few ways that, but again, packaging matters, right?
Kind of like destigmatized HIV as well. It's like, and also like think about get a more general approach to sexual health. It's like part of your general health. I remember when I was doing kind of similar HIV promotion back in Asia, and we also always talk about men's health, women's health, rather than kind of like they kind of like more general space to speak to a more general population. And I remember when I first came to Australia, I worked with ACON, and then the ACON Asian Gay Men Project, and then they do a lot of them. They do a lot of amazing work. But remember that one day they were holding us event in cinema and then putting out a huge banner here for Asian gay men. I was still in this country. I was like, if I were from a very conservative country, I wouldn't come here to talk to you. I would just feel like a bit uncomfortable. Maybe sometimes like we can, as you said, be a more kind of a normalizing kind of like a hidden discreet message to kind of like reach people that that they may find it more comfortable. Any other panelists would like to speak on this question?
I think it's just really hard to find the balance that works for every single occasion. So, like Horace, what you just described made me laughed out quite loud. There's no one else in the office, so I can do that. But yes, I mean, the whole point of having that huge Here for Asian Gay Men banner is to make Asian gay men feel less, they can try to hide less. We want people to be able to express their sexualities to the extent that they are comfortable with. And that's why we hold such a gay banner in public spaces. But at the same time, there are people who don't want to rub their sexual orientation and their sex lives onto, the other people's faces. Like I don't think we can ever find a balance, a perfect balance between promoting sex positivity and respect people's traditional or more conservative values, because both have meanings to each person, right? So I think what's really important here is to understand that we need to create spaces that would allow different, even if they are conflicting to each other's kind of approach to exist.
Yes, and recognizing there is not only one community, there are lots of different communities within the community. Okay, the next question is probably the final question from the audience about given how busy GPs are and the wide range of health concerns they manage each day, what can health agencies or government bodies do to better engage them in conversations about becoming S100 prescribers and supporting safe, inclusive care for the GBMSM community? So probably these questions will be for David. You're on mute again.
Yeah, so for the S100 prescribing, I mean, I came from the UK where we did a lot of shared care with GPs. It doesn't seem to happen very much here. As a lot of people with HIV are getting older, a lot of the things that they need are focused around aging, metabolic problems, your cardiovascular risk. These are things that, sexual health doctors are not particularly great at. I mean, this is much more the remit of general practitioners who deal with this every day with multitudes of patients. So I think, it's less threatening for GPs if they could think about shared care models than necessarily taking over all of the care of a person. For some GPs, they love the HIV work. They're happy to do the S100 course and they work in centres in the city. But we need more people out in Greater Western Sydney, out in rural New South Wales, other parts of the country to be able to support the workforce. I think the other thing that's important that maybe we haven't addressed it enough yet is the multidisciplinary team. We haven't said much about nurses or social workers, but they're both also incredibly important parts of the workforce. And I think that we all work together. I think I alluded to earlier that we do need to understand everyone's coming with different skills, and you don't have to do everything yourself. So for a general practitioner, it's important to be aware of who else can help with various aspects of what needs to happen for making sure we provide the best care for people.
Thanks, David. As an HIV nurse myself, I totally agree with you. That's a multidisciplinary approach, and thanks very much for bringing up that. So,
Yes.
yeah, and I think probably to finish, probably I would like ask each panelist to give probably one brief practical takeaway to the audience. What is one thing you would like the healthcare workers or healthcare professionals or services to do differently after tonight's webinar? Just please keep your response really, really brief, maybe 1 or 2 sentences. Who would like to start? Yes, Diego?
Yes, I think the two topics that are kind of the not the novelty, but the one we want to push the most of this guide is pretty much trust in the peer support network that we are lucky to have in Australia. So we are not an optional support anymore. We should be part of the HIV care from the very beginning to the very end, if there's an end. So have us in mind as you will have in mind a psychologist or a counselor. And the other thing is, please learn about migration. Even the limited information that is on the guide is enough. You don't need to know more about that. And there's other sources there that Hulk has done, etc. Those two will make you a better professional when you work around call overseas born people with HIV.
Thanks, Diego. So Billy or Justin, would you like to talk about what one kind of like takeaway you would like the audience to do differently? Maybe Billy?
Okay. I think very short. Don't shy to ask. I think like it's impossible for you to know everything. And then a lot of the people here is very friendly anyway. Just ask, like if they don't know, hopefully they will point you to another directions that will help. Right. So
Thanks, Billy. Justin?
I think the one thing for me would be just remember an HIV diagnosis often means more than a chronic disease to this particular population. It often requires a new reinvention of one's whole sense of self. So be kind, be curious, and keep that in mind.
Thank you. And Nathan?
Yeah, one for me would be just around communicating about undetectable viral load and the zero risk of zero HIV risk. And not just assuming that, you and you equals you is always packaged as this nice sort of simple, easy to understand message, but for a lot of people, it's not. So I think taking time, not just to say it, but to help people sort of believe it at the same time.
Thanks, Nathan. And last but not least, David, what message you would like the audience to know? One takeaway.
Yeah, my takeaway would be to focus on the quality of life of the patient in front of you, because that's what it's all about, patient-centered care. Use tools. There are tools available to help. I found them incredibly useful. Actually taught me a lot about, when you're strong mentally, you can cope with a lot of other stuff that comes your way. But often people hide often the physical side of things, they'll hide it from you. And if you don't ask and find out what the patient really knows, or they really understand what's going on, you'll miss out, and they miss out on a huge opportunity, because the time they have with you is very valuable. It's not a lot of time in the reality of life, but you want to make it count as a patient, and you want to make it count as a clinician.
Okay, thanks very much. Thank you all of the panelists for those thoughtful reflection tonight. It has been a really valuable to hear the clinical, the peer, and the lived experience, and also research perspective that bring together tonight. And thank you all the audience for joining us, for contributing to a more inclusive, culturally responsive, and person-centered HIV responses. There should be a evaluation form that probably will email to you later. So anyone,
Thank you, Jubes, as well, to put this together.
Yes, just let us know, fill in that evaluation form. And also thanks very much for joining, and have a safe and pleasant evening. Good night, everyone. Bye.